Good evening, everybody. On behalf of IOCON 2020, the organizing chairman, Dr. Ajit Shinde, organizing co-chairman, Dr. Shubhranshu Mohanty, and my entire team, I welcome you all for yet another academic threadbare discussion as a part of Bounce Back. Bounce Back is the way that we believe that in these testing times, we can bounce forward from where we have been pushed by this COVID-19 crisis. I'm sure that the young brigade today is going to decipher situations which look very simple, simple fractures which are not very simple. We as orthopedic surgeons tend to look at bone, bone, and bone, showing at times scant respect for the soft tissue. A young group of experts led by the convener, Dr. Ashish Phadnis, a brilliant trauma surgeon himself, and 4 leading young Turks, each one who will rise to be a huge Parag Shah, who is coming over from Ahmedabad, Dr. Parag Lad, Dr. Miten Sheth, and Dr. Abhishek Kini. These 5 minds, supported by the techno-whiz, Dr. Ashok Sham, would lead us through a threadbare discussion on 4 very, very important aspects of not very simple looking situations if we decide to involve ourselves, intrigue ourselves, and look deep within. There is a lot of learning in the next hour and a half, and I suggest each one of you on this Saturday evening pay special attention to what these young subspecialists share with you. All that we are going to discuss today is something that a general orthopedic surgeon would be attending to. But having this information transformed into knowledge will then crystallize into wisdom, which you can use for the welfare of your patients.
Thank you very much, Dr. Ashok. Thank you very much, Ram sir, for those encouraging words. And I would like to thank the IOA and the MOA for this great initiative. And as the name suggests, it's a threadbare discussion on certain aspects which we generally tend to sort of overlook or have been faced with certain situations where we wished that we were slightly better prepared for that situation. There are these fractures which are not very uncommon: the wrist fractures, the knee fractures, ankle fractures, and fractures around the elbow that an average or any orthopedic surgeon would encounter numerous times in his practice, and once or twice we are caught off guard. So a lot of knowledge has changed, a lot of concepts have evolved, and a lot of devices are available to us when we feel that, oh, I wish I would have had an ethibond, I wish I would have had this particular plate or that particular anchor. So when to be prepared, how to be prepared, and how to look for these signs which can save you from trouble, especially in the simple looking fractures, which often leave a bad taste if not managed very well. So I have got a very good team who are experts in their own respective field and very good speakers. I would like to welcome Dr. Parag Lad, who is an accomplished hand surgeon, Dr. Abhishek Kini, who is a foot and ankle and a sports surgeon, and Dr. Miten Sheth, who manages everything around the knee. So these, and Dr. Parag Shah from Ahmedabad, who is a specialist in elbow surgeries. So they would give you an overview because they have seen these problems, complications arising right from the trauma to the point when it becomes a cold case or a sort of an elective case. So they bring in their 360-degree experience in managing these particular cases. I would like to invite Dr. Miten Sheth at this point to talk about the associated ligamentous injuries, which are associated with tibial plateau fractures, which a lot of times are picked up intraoperatively. We do preempt them a lot of times as well, but how to tackle them, and so that we have a stable knee along with a stable fixation at the end of the surgery. Over to you, Miten.
Right. I hope you can hear me.
Yeah.
So today I'm going to talk on these tibial plateau fractures accompanied by multi-ligament injuries. I want to thank the IOA and the MOA for giving me the opportunity to share my philosophy on this very peculiar situation. Why peculiar? That's because, of course, there are no relevant disclosures at this talk. This topic, most of the times, has a lot of level 3 and level 4 evidence, but no great level 1 and level 2 studies to drive treatment and management. So some of it is developed over time as a philosophy, and that's what we are going to discuss. We start with just a model of the knee to try and understand what the bones and the soft tissues around the knee are about. So when we talk about tibial plateau fractures, of course, we talk of this region just in case there is a fracture here. So femoral condylar fractures and patellar fractures are not included. And when we talk of a ligament injury, we are not talking only of the ligaments per se. We are also talking of other tissues that include the medial and the lateral meniscus and the accompanying muscular tendinous structures. So essentially the ligaments are four. That's the medial collateral ligament on the medial side, the LCL or the FCL on the lateral side, the two cruciates in the middle. And then you're talking of the medial and the lateral meniscus, the entire extensor mechanism that can include the quadriceps tendon and the patellar tendon, the tibial tuberosity where the patellar tendon is attached. On the lateral side, the anterolateral capsule, the iliotibial band, and going behind the posterolateral capsule, the popliteus tendon. On both the sides, the lateral and the medial gastrocnemius, all these with the capsular envelope. So if you have a tibial plateau fracture, you're only thinking of the bony injury, but there is a substantial portion related to the soft tissues that we need to discuss. In addition to these, we are also going to discuss some things pertinent to the common peroneal nerve and of course the popliteal artery. So for all those who are trauma surgeons, great proponents of the AO philosophy, tibial plateau fractures can be classified according to the Schatzger, the AO classification, or divided into 3 columns. And then for arthroscopy and sports medicine surgeons who are more focused towards the soft tissues, they're generally not seeing the bony injuries and they're seeing knee dislocations. So they've been traditionally taught to divide everything according to the Schenck classification, where everything goes from a KD1, that's a single cruciate, KD2, that's a bicruciate, KD3, that's a collateral ligament injury with both cruciates involved, can be medial or lateral, a KD4 where all 4 of the ligaments, both cruciates and both collaterals are injured. The knee is dislocated, but there's hardly anything broken in terms of bone. What we are going to discuss today is looking from the trauma surgeon's perspective, a fracture dislocation. That means a fracture with a ligament injury. Or from the arthroscopy surgeon or the soft tissue surgeon's perspective, a KD5. A KD5 is a periarticular fracture along with a knee dislocation. So essentially, tibial plateau fractures with ligament injuries can involve 2 kinds of situations. One, where there's a condylar fracture, the tibial, medial tibial plateau, lateral tibial plateau, something big happens to bone and there is ligament injury. Or there's a predominant knee dislocation, that means a great soft tissue ligament injury with a small periarticular fracture like the Segan's fracture that you can see here, or an ACL avulsion, or a PCL avulsion, or an anteromedial capsular avulsion. Why this is important is it is established beyond doubt that if we treat only the bone and fix only the tibial plateau fractures, ligament injury, if present and left untreated, will result in a poor outcome. Also, we've seen the flip side. If you have a a KD5 dislocation, if you treat the fracture component in the dislocation, it's definitely going to improve the outcome. Of course, there'll be naysayers amongst all of us who say that, yes, we know that there's a lot of soft tissue injury involved with the tibial plateau fractures, but hardly any of them require surgery. So I'm going to discuss two specific situations where I feel that most trauma surgeons neglect the soft tissues, but they're better off assessing in these two particular situations the soft tissues and then offer surgery to the patient if it's really needed. And these are very two common situations. The principles of management are very standard. So if you have a tibial plateau fracture, you want to establish three things: alignment, articular congruity, and when you have both of these in place, when you fix the fragments, you want them to hold in place. You want the skeletal stability. When you're looking at a knee dislocation as such, these three issues are pretty much solved either ways. So you're looking at joint stability. You want the ligaments to hold the knee joint in place. And those who dwell into deeper details are concerned about the two menisci because they want them to be right so that the contact stresses are better handled. Now, if you have a fracture dislocation or a KD5 dislocation, that's a periarticular fracture, you have to think of all of these five things. Because if you don't, then you're going to miss out on the alignment and you're going to have a situation where there's going to be malalignment. If you don't handle the congruity, there's going to be a problem. If you don't fix the tibial plateau fracture and just focus on the ligaments, you're going to end up with a situation of a delayed or no union. If you fix a little less or leave out a few ligaments and fix only the bone, you're going to come back, the patient's going to come back with instability. And if you're overzealous and you're going to tackle all the ligaments at the same time, in addition to the tibial plateau fracture, and operate for 3 and 4 hours, you're going to have the patient coming back with stiffness. And of course, all of us are afraid that infection may set in, and that's a completely different scenario. How do you approach these? So the type of injury, the energy involved, and the direction of force is very important. Essentially, we are going to have three kinds of patients. So there's going to be high velocity trauma, and most of these is going to lead to a very high level of injury to the bone and soft tissues. A huge proportion of these cases are a part of polytrauma. So there's a lot of other injuries involved, like there may be pelvic discontinuity and a lot of other issues where maybe just focusing on the tibial plateau and not dwelling into deeper details of the ligament injury may make sense. And the ultra low velocity injuries, on the other hand, seen in very high BMI females with osteopenic bone, they may have they have a propensity towards greater compression fractures or avulsion fractures. But if you treat the bone, maybe these patients also don't have great demands. So they may not come back complaining of an anterior posterior instability, and you may still get away by not tackling the ligaments. So high velocity injuries and ultra low velocity injuries, if you handle the tibial plateau fracture per se, good idea. Probably the patient's not going to come back to curse you for not tackling the ligament issue at the same time. But the focus of this talk and most of the clinical practice that we see is of this combination of low velocity injuries where they have tibial plateau fractures and grade 3 ligament injuries, and you can see only bone. So you've tackled only bone, and the patient's going to come back to you and not be happy. So you must prioritize treatment. Of course, life is important. So doesn't go to say that this talk propagates the fact that all ligament injuries with tibial plateau fracture should be handled. The limb comes next, and the vascular supply is very important. So certain fractures, certain PCL avulsions because of great hyperextension injuries, certain KD5 dislocations are accompanied with popliteal artery issues. Now, there may be a medial tibial plateau component, an anterolateral tibial condyle component, but this picture here goes to show that if you have a PCL avulsion, if you are having an arterial problem and the vascular surgeon is going to open up the limb from behind, you can fix the PCL avulsion at the same time as the vascular approach. no plating or great implants going in at that time. Time is of value. But certain fixations like the PCL can be done when the vascular problem is being tackled. Similarly, if you have a nerve compromised situation, and the nerve that we are talking about is the common peroneal nerve, that's on the lateral side. And for some reason, if you have to explore that, then this is one situation where you can tackle a fibular head avulsion, anything on the posterolateral side primarily, because it's the plastic surgeons already opening that particular area. So I want to go into a little detail about the nerve compromise. Most of the times, if there's an open injury, obviously you're going to go in there and look for the nerve and decompress it. But there are particular situations with a closed injury, especially if in the 2 weeks you're seeing a lot of edema on the MRI and the patient has a palsy. You're going to explore and decompress the nerve. And this is the situation that I'm talking about as a soft tissue surgeon. You shouldn't be thinking that, okay, tibial plateau fracture is to be handled later, and right now it's just the plastic surgeon who's going to decompress the nerve. You can actually tackle the soft tissues on the posterolateral side of the knee at the same time through the same incision. And this is a very nice algorithm that talks about the recovery from a complete common peroneal nerve palsy, where essentially exploration and decompression can find two situations: when the nerve is in continuity or there is a gap, and if the gap is too huge or the gap is minimal. Now, the fourth situation to prioritize treatment is an open fracture. So you first concerned about life, then about the vascular compromise, and you're checking ABPIs during a polytrauma. Next, you're looking at the common peroneal nerve situation. The fourth situation where you can primarily tackle the ligament and soft musculotendinous structures around the knee is an open fracture. So if you see, look over here at this picture, there's a patellar tendon avulsion, and this is something that can be tackled primarily through the open wound itself. So you don't wait for a stage procedure and wait for the bones to be stabilized and then go back inside and treat this soft tissue wound. The fifth thing that we're looking at is a soft tissue sleeve injury. And you can categorize these according to the Schoen classification or have your own way to look at them. But you're looking at the location of the abrasion or the contusion. If there is a dislocation, then you want to keep it reduced. If you suspect that the soft tissue injury is really massive, then you're going to immobilize the limb. And if the knee is unstable or the soft tissue injury is really great, or there is an open wound or there's a neurovascular problem, you're going to put in a fixator. You're going to keep checking the compartments and the status of the soft tissues. Wait for a minimum of 72 hours for the inflammatory response to reduce, and sometimes for a week, because if you're going to scope the knee to treat the ligaments, then you want the soft tissues to have healed and the capsule to have healed, which would take about a week. So this is important because many a times we receive calls from my colleagues who are going to put in an external fixator for a tibial plateau fracture, and they ask this common question that, okay, I have a tibial plateau fracture that's looking unstable and I'm going to put in an external fixator. Do you want to do some soft tissue work at the same time? The answer is a clear-cut no, because if you don't find the soft tissues good enough to fix your fracture with plating, then of course the soft tissues are not good enough to go inside and treat any ligaments. So an external fixator indication means all treatments around the knee should stop and wait. Now we come to certain very clear observations, and these are very interesting, and that will bring me to the two situations that I want to discuss. More energy means more displacement. More energy means more splaying and depression of the tibial condyles and more soft tissue injury. Most of the times, if there's a varus valgus component or a flexion extension component to the fracture, obviously there are going to be avulsions or disruptions on the tension side. Now, again, this is evidence-based that if you have a lateral tibial plateau split depression or a pure depression, the medial side is under tension and MCL tears are the commonest, around 20 to 30% incidence. So if you're treating anything on the anterolateral side, make sure that you're thinking about the medial side too. Second, if you have a medial tibial condyle fracture or a bicondylar fracture, then the incidence of ACL avulsions is almost around 40 to 50%. So look for ACL avulsions in those scenarios. Third, if you have a depression on the lateral side that's more than 5 mm, and I have cancelled out splaying here because if you're seeing the lateral tibial plateau splayed out, yes, that means there's an injury. But if you're not seeing it splayed out also, maybe the sagittal X-ray is showing some anterior-posterior displacement of the condyle. So splaying is not a great criteria to think about the energy impacted. If there's a depression more than 5 mm, then there is a chance of a lateral meniscus tear. And when we're talking of these ACL avulsions, there's a very peculiar sequence of how this happens. Most of the times, the initial impact of the energy is to the anteromedial tibial plateau. That continues to the ACL insertion and avulses the ACL off. And because the ACL comes off, the tibia sort of translates ahead and the femur hits the tibia, and most of these patients also have posterolateral tibial plateau fractures. Even simple ACL tear MRIs that we see many a times have posterolateral tibial contusions. So what's the timing of the soft tissue injury we should offer? If the soft tissues are great and the trauma surgeons placing in the plates for fixing the tibial plateau early, we must think of repairing all the soft tissues, everything that's possible at the same time. And if there's an external fixator in place and then you're going to go in for definitive stabilization later, or you happen to see a patient 3 months after a tibial plateau fracture, you can't directly go in and think about the ligaments. You must go back and think about union, alignment, and congruity, and then decide on the repair versus reconstruction. And 3 points that we can always keep in mind here that we're thinking of, and these are not, these are just general guidelines, not everything taken to per se. So collaterals first, and we think of cruciates later. At the same time, we always must consider that the PCL is the pivot of the knee and pretty much very important to the stability. So if you're actually thinking of just doing collateral work, maybe the collaterals will stretch out because the pivot of the knee is missing. So if there's a PCL injury, we are always trying to think of treating that first. And then we are thinking of combinations. So the PCL and the posterolateral capsular structures go together. Grade 3 ACL, MCLs are always treated together, and so on and so forth. And if you're thinking of how to decide between repair and reconstruction, the commonest injury that we see with tibial plateau fractures is an MCL. And up to 6 weeks, we're just thinking about repairing, augmenting, or conserving the MCL. And unless we're seeing something at 2 months and 3 months and a year after surgery with grade 3 instability, we are not thinking reconstruction. The posterolateral structures, funnily enough, most of the recent evidence says that primary repair doesn't do well. So even if we're seeing a patient with a grade 3 dial or a PLC injury, we're thinking of reconstruction rather than repair. ACL and PCLs, most of the mid-substance tears are treated with reconstruction. In fact, all of them. Certain situations, exceptions, very rare, but you may have a situation where there's an ACL or a PCL femoral soft tissue peel off in the notch, and you may fix it primarily. All bone avulsions are repaired and all mid-substance tears are reconstructed. If you do all of it, you're going to risk arthropibrosis, and if you do less, you're going to risk instability. So we come to those two situations that are very frequent in routine practice, and most of the times nothing's being done about them. So this is how you should think about these two situations. So if there's a 50-year-old male and living in a chawl, falls from the ladder and comes to us with pain and swelling, and we do these x-rays, if you look at them for a bit, you may just dismiss this as a routine soft tissue injury and send the patient home. But the patient has a lot of hemarthrosis. You can see this on the lateral x-ray. And you're thinking, maybe we need to know more. And because there isn't great bone component injury that you see, most of these will be subjected to an MRI. Vis-a-vis, if you're seeing bone issues, you're going to be subjected the patient to a CT scan. So the MRI shows a lateral tibial plateau depression, and there is a fracture and some splaying involved. Now, to most, this isn't very significant. At the same time, you're going to be looking at the cruciates and the collaterals, and you can see that the MCL has some injury on the tibial side. This patient, we happen to do a CT scan as well, and you can see a depression that's significant, around 4 to 5 millimeters, 6 millimeters reported on the CT scan report, and it's all in the anterolateral tibial plateau. So how are you going to start thinking about this scenario? So you have this patient who's 50, and you can think of alignment first. And if this patient has inherent constitutional varus, that means most of his weight bearing is happening through the medial side, you can very well conserve this patient and he'll have full range of motion, because in flexion, we know that the normal femoral rollback will push the femoral condyle towards the back side of the lateral tibial plateau, which is normal in his case. And then he can go in for a knee replacement in a few years. You can actually be concerned about the articular incongruity and think that, okay, we must raise this because this is 6 mm. And we know that any depression more than 6 mm will have a meniscus issue as well. If you want to fix, then you're thinking about how to get this stable. And of course, you're thinking about joint stability, because this is a low energy situation, which is one of the star hallmarks where you can do soft tissue work. So do you conserve? Maybe not, because the depression is significant and there is splaying, and both of these means that there is a lateral meniscus component involved as well, which is seen on the MRI. There is an MCL component as well. So how do you approach this? Are you going to take an anterolateral incision and just put in screws, rafting screws or a plate? In which case you would be expected to do a submeniscal arthrotomy always, because we know that anything in the lateral tibial plateau always gives rise to lateral meniscus injuries, and you can see the lateral meniscus at the same time. Or you can just put in percutaneous, you can raise the depression and put in percutaneous rafting screws and scope the patient at the same time and tackle the lateral meniscus, and also see whether the reduction has been done right. What do you do about the ligament? It's very important that you do two things in all these fractures, Schatzger 1, 2, 3. One, that once you fix what's there on the lateral side, you must do a valgus stress. You must, before you start the case, always have the opposite leg also in sterile situation. So you compare your valgus stress on the affected side with the normal side. And if you see a gaping difference of 5 to 10 mm, then it's imperative that you tackle the MCL at the same time. Second, if the MCL does not open up to that extent that you feel, you must remember that still this patient has a grade 2 MCL, and throughout the rehab, at least for the first 6 weeks, this patient must receive a hinge knee brace. So what we did was put in a small anterolateral window, used a bone tamp, and we have these tamps because we do these Oates procedures also as arthroscopy surgeons. And you can visualize the depression while doing the scopy, raise it up, put in 2 rafting screws. At the same time, once this was fixed, you give a valgus stress and check if the knee opens up or not. In this case, it didn't open up. And so if it doesn't open up, you use a hinge knee brace. Second scenario, you're seeing a posteromedial fracture, huge fracture. You can see it on the CT scan as well. So what's the thing that should strike? If you have a Schatzger type 4, 5, you have to look for an ACL avulsion. So as you can see here, there's a Mayer-McKeever type 3. So that's type 4, that's comminuted. And what we did in this case was put in a posteromedial plate, fixed everything. And this was at around 10 days post the injury. And you can trust the capsule to have healed by then, and you can go and do a primary scope and fix the ACL avulsion with a suture bridge technique. Similarly, if you see a fracture like this, another patient, huge ACL avulsion and a posteromedial condylar fracture, You can see it on the MRI as well. So you put in a posteromedial plate. If you don't want to scope the patient, just let him get back the full range and come back to you in 6 weeks and 8 weeks. And then you can subject the patient to a scope and fix it with a screw or with suture bridge or any technique that you're comfortable. So the principles are, if you're seeing the patient early, then just focus on these 5. If you're seeing the patient late, you still focus on these 5. Alignment, most important. Next comes congruity. Then you see if the patient's coming to you at 3 months with pain, then it's not the meniscus that's giving the patient pain, it's delayed union or poor union. If you have union, then you think about the meniscus. And as far as the ligaments are concerned, all the ligaments are doing is give the joint stability. So you treat the red first and the green second, and then you're in a happy situation. Thank you.
Thank you, Miten. Hello?
Yes, I can hear you.
Yeah. So, Miten, I wanted to ask you a couple of questions for the benefit of the audience as well. Now,
Sure.
Traditionally we've been led to believe, or we believe that these ACL avulsions which are there, they say that though we reconstruct them from the, we put the bone back, we put a screw on top, but functionally the ACL is deficient because it has stretched to its limits and then it has avulse. So does the same hold true in an ACL avulsion along with the tibial plateau fracture?
Most of the times, no. So, of course, this analogy, I mean, I would add to this discussion that we are having here that if you're looking at adolescents and pediatric patients who suffer from ACL bone avulsions, most of the times those, because they are isolated ACL injuries, the ligament soft tissue structure, unlike the adults who are facing the tibial plateau fracture, is really good. And it's just the bone, the eminence that's weak and that's coming off. Of course, the situation is different in patients, like you said, who have adults with a tibial plateau injury, where there may be a certain stretch involved to the mid substance of the ACL. So if you have a bicondylar fracture, this is what I've observed. Most of the times, you're looking at depressions on both sides, and you're raising the lateral tibial plateau with the ACL as a reference many a times, and the medial tibial plateau also as a reference. So in most scenarios, the island that has the ACL attached in the middle gets reduced, and you don't really need to fix them. But the ones that are fixed, there are very few reports that say that we fixed the ACL avulsion primarily and still the patient had anterior posterior instability. There is in fact no paper in literature that talks about this. Yes, theoretically you're right, but there is no patient that comes. In fact, the reason why people don't do it is because we are fearing the reverse, arthropfibrosis.
Right. Okay, so are there any instances when you had to go back and sort of, the screw which has been put for the ACL footprint is the source of the problem? Does that ever happen?
So
like you said, arthropfibrosis. So when you're talking about like a cyclops lesion, or let's say the
it's
screw
not
has
cyclops,
a
it's direct impingement per se.
Yeah. So does that ever happen commonly? Or you're not heard of, I mean, you're not come across such a situation?
It has happened. It has happened. So this happens when you're a little over enthusiastic, and it happened to me twice in say around 3 years back, where I was really confused whether to fix these ACL avulsions when fixing with a screw, with a washer, without a washer. And I really didn't know the depth of the screw. And if you're using the washer and you have like a type 2 Mayer-McKeever, where there's just an anterior beak to the ACL avulsion, and if you don't get the trajectory right, the beak stays there and you just crush the entire ACL fragment down. But because of the washer, the entire construct is really proud. And then the patient's coming back to you at 2 months and 3 months with 5 to 10 degrees of flexion deformity, unable to straighten.
Yeah.
And at those situations are the worst, because you're going to go back in, remove the screw and the washer, and you're wondering whether you want to again fix the ACL because it wasn't fixed right in the first place.
Right.
But you just leave them alone.
Right. But in your experience, I mean, do these patients who have got polytrauma and who have been through such a lot of sort of, trauma, reparative process or stiffness, Do they complain of instability, or is it the stiffness that usually is the problem in such patients?
If they've been treated well with good alignment, articular congruity by the fracture surgeon, or we treat the tibial plateau well, there is no reason why patients shouldn't get back full range of motion. If they get back full range of motion and they are young, athletic, and have good demands, know what they want to do, if there is a grade 3 tear, they will have instability.
Okay. So, in the interest of time, I'll just limit one or two questions more. So, two questions. I mean, you mentioned that the PLC nowadays there is a tendency toward reconstruction rather than repair. A
Yes,
lot of these tibial plateau fractures we also see with a fibular head fracture,
yes.
and very often than I mean, more often than not, I mean, we are not very enthusiastic with the varus valgus stress at the end of the fixation, but then sometimes you do see that the fibular head actually is avulsed and is flying off. So, are there any, I mean, tips that you can suggest that we keep those armamentum ready, let's say anchors or any ethibond or special suture material or fiber tapes in our OT, so that you can go and address
So
the
the fibula
situation?
head avulsions are what we should be really scared of. If you see
Hmm.
a fibular head avulsion, first thing to your mind, common peroneal nerve. Something's going to be amiss. If it's not, and the patient has no neural deficit, these are the patients that are really difficult to treat, because once the fibular head comes off, say from the it's the biceps femoris attachment that's coming off, most of the times the nerve moves with it. So if you're planning to fix these also, you have to be really careful. And we would unless it's really displaced, uh, be scared to fix it, because the exposure involves a very different way other than convention, where we generally go take the incision and look for the nerve, isolate the nerve close to the fibula or a little proximal or distal depending on personal preference, and then treat the things over there. But if there is a biceps femoris avulsion, then this pathway is totally ruined, and you're going to find it really difficult to isolate the nerve. And if you don't and just try and fix these fractures directly with a screw or something, then it's likely that a patient with no deficit pre-op may have something later.
Okay. Coming to the next ligament, which is there, is the patellar ligament. I mean, the ligamentum patellae more often than not gives us a problem because it is usually attached to a big chunk of bone, which we try to fix in with lag screws and try to fix this thing back. But we do see problems associated with the the patellar ligament. Now, if a surgeon realizes that the footprint or the tibial tuberosity is very comminuted, are there any other mechanisms that we can use to put it back in
Yeah,
position
yeah.
other
So I
than
think
like
four things always need to be there with all people who are fixing anything close around the tibial plateau or the femoral condyle. You need to have a suture disc. You need to have ethibond and ultra tape, or that's high molecular weight polyethylene tapes now instead of sutures. You need to have staples,
okay,
and of course your screws, just in case there is any avulsion anywhere. So
right,
if you, as long as there is no soft tissue tear of the patellar tendon from the top or the bottom, you are in happy space, because anytime bone comes off bone, even if it's comminuted,
okay,
you're always going to be able to put it back in place. So you can use these staples, two together, very
yeah,
close to each other, and just put them in. The only problem is most of the times when we even use the screws to fix it in, we're going absolute anterior to posterior, and
yeah.
which makes it very difficult to close the incision then, and gives a lot of issues. So if you can get a way to make put in two screws that are orthogonal, so to say, in a different direction, then most of the wound healing issues are also solved.
We are towards the end of the session, and I would like to wish you a good weekend ahead, and hopefully we should bounce back pretty soon. Thank you very much.
Thank you very much, sir.
Thank you. Thank you.